Okay, I think we should get started. So hi, everybody. I'm Lucia Knight, and I am the head of the Division of Social and Behavioral Sciences. So welcome to our session for today. We're very pleased to have Myrna van Pinxteren, sorry, Myrna, I was always going to murder that, joining us today, who used to be a PhD student in the division and is now a postdoc in the Chronic Diseases Initiative for Africa. So she hasn't left UCT or the faculty altogether. But Myrna finished her PhD last year, so congratulations, Myrna. I don't think we've celebrated that enough because it kind of happened in the midst of other things. And we're very pleased to have Myrna joining us to present some of the results from her PhD. And so, Myrna, you can go ahead and then we'll take some questions and have some discussion after you're done.
Okay. All right. Thank you. Thank you so much, Lucia. I would like to ask you if you can tell me about like 5 minutes before I run out of time, so I don't leave, that I leave enough room for questions.
Sure, with pleasure.
Okay. All right. Great. So hi, everybody, and thank you so much for this invitation. It's lovely to be here. So my name is Myrna, and I'm a postdoc researcher, as Lucia said, at the Chronic Disease Initiative for Africa. I used to work at DSBS both as a PhD candidate as well as a research coordinator in the ILAM team. And I have a master and honors also from UCT in social anthropology and a bachelor in journalism. My expertise are mostly in ethnography, qualitative data collection, and intervention research. And if you ever want to get more information, especially about the ILAM project, please visit the website. So today's sort of presentation is very straightforward, starting with background methods, and then the 3 different case studies that I developed for my PhD thesis, and a little some ideas about the discussion, and then I'll make sure to leave enough room for Q&A. So firstly, a bit more about ILAM. So ILAM stands for Using Information to Align Services and Link and Retain Men in the HIV Cascade. It turned out to be a 7-year project ending this year, aiming to improve linking men to the HIV cascade by better understanding their barriers to care, as well as to share information about HIV and health services to a group of dedicated stakeholders, the ILAM task team, and the larger community. The project is based in Gugulethu in the Klipfontein sub-district here in Cape Town. And it's a mixed methods research project with a smaller quantitative component, but a large qualitative research component. Even though the research was initially a 5-year research, we've done some additional case study research by my colleagues, Yandisa and Nonzuzu. And we've also established an international men and HIV research network, which was established to put the rights of men more firmly on the HIV agenda. So just to give you a little bit more information about health information use in South Africa. So health information is crucial for decision making within the health system. In South Africa, we mostly focus on the use of routine health information, which is stored in routine health information systems, databases especially developed to collect and store health information. In low middle income countries, routine health information systems are often developed in a very technocratic and fragmented way, which hinders the flow of data. And the access and use of health information is furthermore impacted by technical, organizational, and communication challenges. In South Africa, routine health information systems have been mostly redesigned on district level post-apartheid, and this process was largely informed by the need for accumulating lots of HIV data to structure the HIV response, as well to upscale HIV services and to better track testing and linkage of patients to care. In South Africa, but also in other countries, routine health information is mostly used by health managers. So although we do know a lot about especially routine health information within South Africa, and there's quite a bit of literature around it, there's still a lot to discover. And despite the developments in the context of the South African health information systems, there are still lots of questions around the complex role of health information in the health system, as well as how we can meet the demand for health information and monitor the impact of this information as part of improving the health system. So there's several questions that we would like to have answered and that I focused on in my PhD. For instance, who might be interested in health information but doesn't have access to it? Think about here around frontline health workers, community health workers, or the larger community. Besides routine information, what other types of information are used in the health system for decision making and strengthening health services? You can think here about informal information or non-routine information, which can include conversations, tacit knowledge, experiences, narratives, etc. This information is often not collected in a routine manner, as it's hard to measure its impact, but several scholars have been writing about this. I was also especially interested in how exactly is health information used to strengthen health systems. So here we're talking more around like the semantics of health system use. So for my PhD especially, this led to three research questions. The first one being, how do both frontline workers and community representatives access, produce, and make use of health information within the Gugulethu context? But also, what are the factors that are hindering or facilitating the access to, production, and use of health information? And what strategies are used by frontline health workers and community stakeholders to improve the access to health information in Gugulethu, and what is the effect of those strategies? So eventually, I will come back to this later, but eventually I was able to, through doing using different research methods, I was able to use to develop 3 ethnographic case studies. So first, a little bit more about the methods. I was lucky enough to be employed within ILAM since 2016, and as we already started the project and did formative research within the community, I was able to step in and immediately go out into the community, which resulted in more than 18 months of fieldwork in Gugulethu and ongoing engagement with both the ILAM team and my participants. I use a largely ethnographic research design, which included methods such as participant observation, shadowing, interviews, both semi-formal and unstructured. I assisted with health activism campaigns, helped with organizing workshops, and sat in a lot of meetings to observe the conversations. It's very important with qualitative research. I try to be very reflexive throughout my research by writing field notes and diaries almost every day. I also did ongoing data analysis, and I had close contact with my participants. Furthermore, in terms of reflexivity, I also really needed to check in with myself as well as my research with the research team and my supervisors when I was actually conducting research for the ILAM project and when for my own PhD work. So that was something really important to consider. But as these things within this team really went hand in hand, the ILAM task scheme actually became one of my case studies. Although Xhosa is mostly spoken in Gugulethu, my research was mostly conducted in English, sometimes with some translation, but I really found that especially healthcare workers, but also most community members speak really well English, and I was able to have conversations with them without a translator present at all times, which was a real benefit for this research. So just a bit more about Gugulethu. On the left, you see where it's based. It's very close to the airport, just off the M2. And yeah, it's one of the oldest townships in South Africa. It's established in the early 1950s under the Group Area Act, and primarily still inhabited by mostly native South Africans who are Xhosa speaking. You can find in Gugulethu both formal and informal housing, but there's also a lot of infrastructure presence. There are clinics, there is local transport available, there's shops, malls, schools, etc. So it's more and more becoming like a neighborhood. And on the right, you see one of the containers that we use for our field work, our field office. And on the left, next to it, there's the offices of Sonke Gender Justice, our main NGO partner, where we also help the I-Alarm task team meetings. So as I've been working in I-Alarm, which is quite a large research study, I was able to actually meet a lot of people. And as you can see from sort of this cross on this screen, I interacted with lots of people from different parts of the health system, including health system actors, community activists, the I-Alarm task team, which was made out of health systems stakeholders as well as community stakeholders, and the I-Alarm research team. But I sort of wanted to stress that, of course, you have sometimes one-on-one or once-off discussions with people, once-off interactions, but you also have ongoing relationships with some of your participants. And the ones on the inner circle, including Mantla, Sister Vetre, and Pumzile, and some others, those are really the people that I relied on the most for information I could always go back to. They've also, they've given consent so that I could use their names, and they're not anonymized in any of the data of my thesis because, I was able to always have a very good conversations with them about the outcome of this work. So let's go into the findings. As I said before, there are 3 ethnographic case studies. The first one's focusing on health information use within the I-Alarm task team. The second one is the use of health information in the movement for change of social justice, which is MCSJ, a health activism group in Cape Town. And the third one is the use of health information among healthcare workers in program implementation. So let's start with the first study. The I-Alarm task team, was initially an intervention that was developed to improve communication and patient referral between a local clinic, the NY3 clinic, and an NGO in Gugulethu. It led to the development of a dedicated task team, which was a group of health, community, and academic stakeholders who were coming together regularly to share HIV information. But due to the absence of other structures, including the multi-sectorial action team of Klipfontein that was no longer functioning, the I-Alarm task team grew into a consortium of like 20 to 30 health care workers, researchers, NGOs, and community members who would regularly come together to talk about HIV information. In 2017, 18, and 19, we tried to meet bi-monthly and were able to therefore establish good relationships with people within the task team. During the task team meetings, we would share HIV reports with Klipfontein specific data for men in the HIV cascade, trying to improve men's linkage and access to HIV care. But later meetings, especially in 2018 and 2019, were informed by requests of the task team members where people could really say, this is the help that we need and this is the information that we need. Can you assist us with that? This eventually led to additional events and workshops delivered by the I-Alarm team on request. And 2 of them that are worth mentioning are the 2 research in Dabas, which were large community meetings held in 2018 and 2019, where we shared our research findings as well as those of others from UCT who are working in Gugulethu to the community of Gugulethu, and was attended by 500 plus people, which is in this COVID times a bit hard to imagine. So what we did in the I-Alarm task team is that when providing HIV information through HIV reports, we stimulated a call to action within the task team. And one of the healthcare workers saying, we need to have conversations with men in the community, and we need to see what their needs are. This is all about men. But we also realized that HIV reports had data in them. And it was that data that resulted in follow-up ideas and projects to better link men to HIV care. And one of the participants said that the ball is now in our court. We need to create more male-friendly health services in Gugulethu if we want to effectively include men. And the ILAM task team also became a platform to think about non-routine health information as well as non-HIV information. And here, one of my colleagues, Pinxteren, actually shared his story as a sort of living testimony of a man who was living openly with HIV in Gugulethu, and he shared what he would need from the health services and what support structures would benefit men in the community. And as he was very open about his needs, that created sort of a ripple effect among task team members, whereby they started to think about possible ways of sharing that information with the larger community. And Pinxteren was actually invited to give health talks in several clinics in that same month. But we also spoke about more non-HIV information, as of course, health information is linked to other bigger socioeconomic problems that is not necessarily directly linked to HIV, but very important in a larger context, such as alcohol and substance abuse, gender-based violence, men's health in general, and just the state of the health system and what we should and could do to improve that. So there's several results that we can sort of think about when we think about the ILAM case study. And the most important one is that we need to take health information off the shelves. So what I found when doing research on the ILAM task team is that the meetings provided a safe space for information sharing. The meetings were also an opportunity for health workers and community members to have open conversations about what men's health and HIV is and what needs to be done, but also to question patient behavior or attitudes of health staff. Very often, health staff would comment on, but men don't do this or don't adhere to, or patients would say, but health staff is not friendly or not helpful or not available. And it was really nice to sort of have these conversations in a even though it sounds accusatory, in a sort of open manner, and see how you could change these things going forward. The meetings also really strengthened the relationships between clinic staffs, NGOs, and community members, which was repeatedly said within the ILAM task team meetings, that they were really happy to be provided such a space to talk about issues that would arise when trying to, for instance, NGOs trying to work together with health systems members. And the meetings also responded to specific information requests to follow up projects to improve clinic spaces for men, but also to increase health education sharing within facilities. And this is one of the follow-up projects that sort of derived from the ILAM task team, as there was a big call for action to make clinics more male-friendly. And MCSJ sort of took on that project and developed a male-friendly poster that could be hung in the clinics. So it was completely designed by community members to stimulate men to take care of their health. It was designed in COSA specifically with MCSJ members on the front as well. And eventually the poster was endorsed by the Western Cape Department of Health, which allowed MCSJ members to actually distribute this into the community and in the clinics. So the second study is about the movement for change and social justice. This movement was established in late 2016. MCSJ, the Movement for Change and Social Justice, is a group of health activists who work together to improve access to and quality of health services in Gugulethu. They have strong ties within the ILAM research team, as Mantla, one of the founding members of MCSTA, was actually one of our colleagues within ILAM. And MCSTA was established to address the lack of available structures and activism in the community, especially as Mantla, but also other field staff who helped us within the ILAM team realized when going out with students to do research around men and HIV that they were often approached by community members about things in the clinic that weren't working and things that they needed assistance with or issues that they were struggling with. And it really felt that, you know, there wasn't a lack of a structure to sort of address these issues. And therefore, a group of health activists who had different roles within separate NGOs came together and said we should, you know, bundle sort of our expertise and see if we could work together. MCSTA also used different forms of both routine and non-routine health information to develop their own evidence-based campaigns. And as Mantla said within this quote, he said, like, the spirit of activism is very low in Gugulethu, especially on issues of HIV. Kailicha is miles ahead. MSF is based there and different NGOs work together on the issues of HIV and TB. But in Gugulethu, people are working in silos and the community is very complacent. So here I'm going to guide you through a couple of the campaigns that MCSJ developed in the time that I was working with them for my PhD research and working in ILAM. It's not the only thing that they've done, but I focus specifically on these examples as they have a big, health information plays a big role in the examples. So the first campaign that they developed was to improve the dentistry services at the NY3 clinic by collecting self-census data in the community and presenting this data to the dentistry team and the management. So what they've heard was that at the NY3 dentistry, there were people queuing outside from like 3 o'clock in the morning or 4 o'clock in the morning, trying to get a place for the clinic because the dentistry could only help 30 people a day. And if they weren't there on time, then they could like buy a ticket for somebody to stand in line for them, which created quite a big problem with the influx of patients. And to sort of support their quest to get an extra dentist installed and appointed at the clinic, they collected their own testimonies and they went to the clinic in the early hours of the morning and collected all the details for people waiting in line. And they set up a meeting with the, both the primary healthcare manager as well as the clinic manager and the dentistry team to sort of show this data and, you know, stress the need to appoint an extra locum dentist, which they eventually did. And then the second example is that they developed pamphlets and a documentary to increase awareness, to improve sexual and reproductive health education, and distribute condoms in high schools in Gugulethu to decrease HIV infections and pregnancy among teenagers. So this was like, I think, a big passion of Mantla initially, where he was like really worried about the rise of teenage pregnancies and HIV among the youth in Gugulethu. And they, with the help of like ILAM researchers, including myself and Eleanor, who was still working with us at the time, we collected the latest stats from about teenage pregnancy in Gugulethu and condom use and STIs, etc., to develop this pamphlet, which was translated and presented to both the people within the school, so the teachers, but also to the school governing bodies who sort of pledged that they should change their policies and allow condoms to be distributed at school. Initially, this campaign wasn't very successful. So the second step was that they created a documentary whereby they interviewed people from Kailicha from MSF, who had, there are several schools who actually did distribute condoms in schools, and to sort of have positive testimonies about their work, and they presented those in the schools as well. Thirdly, this is actually an interesting example. They were approached by the family physician of the community health clinic in Gugulethu to assist with educating the community about the triage system in the ER at the Gugulethu clinic in the weekends. The family physician first showed the statistics and wherein MCSJ members could really see that the clinic was flocked by patients who were coming from for non-emergency reasons to the clinic because they were not able, for instance, to pick up the medication during the week. And the family physician really asked MCSJ members to go out in the community, distribute pamphlets to explain the triage system and to stimulate patients to actually not come to the clinic in the weekend because the clinic was very overburdened at that time. And MCSJ also invited the family physician to come and speak at one of a large community meeting, and was sort of able to share health information directly from the clinic to the community on request of the family physician. And this one is not part of my thesis, but MCSJ also developed a COVID-19 outreach campaign in 2020 to raise awareness and explain safety protocols in collaboration with the Western Cape Department of Health, where they helped with the tracing of patients who were at risk of contracting COVID or might have been exposed to COVID, as well as to deliver pamphlets to household and also destigmatize the disease, especially in the beginning of the pandemic. And even though it's not part of my thesis, I was involved as a research coordinator, and I've written a piece about it for the conversation, which you can read at your own time. So from the MCSJ studies, there are a couple of interesting results. Firstly, MCSJ produced their own health data to inform their campaigns. Secondly, MCSJ cultivated allies within the health system and allies within the academic space to develop evidence-based campaigns. And here I just want to highlight a quote from the facility manager at Gugulethu CHC, who said to Mantla, "I'll work with you as long as you don't toy in front of my clinic." So he was providing a space for open conversations, but sort of with the caveats that therefore, it should be an open conversation and not a protest. MCSJ also participated in and created safe spaces to explore health information use for their campaigns. They were a big part of the IALAM task team and came regularly, but they also created their own safe spaces, for instance, by calling meetings with health managers to sit together and to explain the reasons why they were there and to explain their campaigns, which proved to be very effective. MCSJ also really leveraged the hunger for information in Gugulethu for their campaigns. They really tapped into the fact that they thought that Gugulethu residents really needed more health information around HIV, and therefore, got quite a lot of support from the Gugulethu community quite quickly and became quite well known. And MCSJ also localized available health information to inform and educate communities. They would use information from the HIV reports, but also information from other sources to bring it into the local context and use that to develop their campaigns, but also to just educate communities in general. And MCSJ also used community brokers to distribute health messages and mobilize the community. They work together, especially with street committees. So they would have a pamphlet or a piece of information that they would like to get distributed through the community, and they would use members of street committees and then educate them and then sort of create a ripple effect to have further dialogues within their streets. And this is a picture of one of the large campaigns that MCSJ had, which was a protest march in 2019 for the whereby community members marched to Parliament to demand the rapid implementation of NHI. And then the third study focused on adolescent health profiles, which is an implementation, more of a policy implementation study. So we got this request during one of the ILAM task team meetings by a clinic manager in Gugulethu who wanted assistance with setting up an adolescent health profile, which is a requirement for the implementation of the Adolescent and Youth Health Friendly program, one of the initiatives to strengthen health services for young people. Basically, the Adolescent Health Profile is a document that outlines the biggest health challenges for youth in the catchment area of the clinic, and with sort of the idea that once this profile is developed, then health workers are better informed about the needs for young people. It was the first follow-up project that derived from the ILAM task team meetings. And the clinic manager spoke about the lack of resources and data to actually develop this profile. So what she commented on, she said, I need to make a whole community profile. It was still, she called it a community profile. Can you imagine? It is something like 8 or 9 pages with things I need to fill in. When do I even have the time to do that or to collect all the information? I need to go into the community to get this information, and that takes time. I could really use assistance from somebody, and I really know that it needs to be done because otherwise I cannot ask for more funding for the clinic. So as you can read from this quote, the clinic manager felt quite lost and also used her links within the ILAM task team to ask direct help from researchers and colleagues. So compared to the other 2 studies, I'm not going to give you examples per se, but rather a timeline about after the request came in from the ILAM task team from this clinic manager, how things unfolded from there. So it started with discussions about the profile as well as the Adolescent Youth Health Friendly program in Gugulethu with the manager. And me and myself and others of the team also assisted drafting the first profile for this clinic. We used a Youth Explorer, which is a database with youth health statistics, as well as clinic data and other HIV information that we collected for ILAM. We presented a first, very rough draft in the ILAM task team meeting in, I think, August 2017. And after that, we received several requests from other clinics, which resulted eventually in a workshop for health workers in 2018, whereby we were able to assist a group of 25 health workers to set up their own profile by giving them a workshop on how to go through the different types of data and the different types of data they could use. We as researchers had also several conversations with implementation partners, as well as the Western Cape Department of Health, about the access to information to develop these profiles, because there was a lot that we still didn't know. And as I was working quite closely with the nurse at the time, I was invited by implementation partners as well as the Western Cape and National Department of Health to give presentations about developing these profiles, as there was a lot of ambiguity around the guidelines and what should be in these profiles. And I think that this case study is very close to my heart, as I worked very intensively with the clinic manager and other nurses to compile this profile, and also went on a little quest to understand what data was required for the profile. And I think also this case study really shows the complexities of working with health information within the implementation space, within the policy implementation space. So the results that sort of came from this study is, firstly, there's among frontline health workers, there was a lack of knowledge about the access to routine information to create these profiles. There also was a lack of support from both from management and implementation partners during the process. There were also a lot of inadequate and ambiguous guidelines and a lack of templates to develop the profiles. But as most of us know and have experience, healthcare workers are very resilient. So they were also able to establish their own strategic relationships to get access to health information, either by working very closely with the implementation partners or with IALARM to sort of really try and grapple with the task that they were asked to do. And healthcare workers also use both routine and non-routine health information to populate these profiles. This included like the routine management reports, but also conversations with colleagues and patients, the use of the Youth Health Explorer, and personal experience and tested knowledge. So here you can see a print screen of the Youth Explorer. It's a platform where you can look at data for the youth per ward, and it gives statistics on health, education, poverty, and crime, and schooling and school dropouts. Data is based on the Stats SA data from 2011, so it's pretty outdated, but at least it's a sort of, for us, it was like a place to start. And for a lot of health workers, it was also a good place to start. So there are several common themes across the case study that you might already sort of listened to. Firstly, there's a need for access to health information for both health and community stakeholders. Secondly, there's also a need to explain the benefits of using both routine information instead additional to routine information, using non-routine information for stakeholders. There's also a need to strengthen relationships between health stakeholders and community stakeholders, so they can they collaborate more effectively together. There's also a need to share routine and non-routine health information among both groups, basically, to create engagement and dialogue to tackle health problems. And there's a need to improve the understanding on how socioeconomic context impacts the use of health information. So this is sort of like the overall themes that came through all three different case studies, which are very different because the people you work with are, you work with and health workers and community actors and academic researchers, but these were the common themes that sort of were highlighted in each of the studies. But I also realized that under the right conditions, health information can definitely be a catalyst for change in the larger health system. And this can possibly be achieved by providing accessible, diverse, and easy to use health information, bringing together health stakeholders and fostering their relationships, but also to arrange a sort of dedicated safe space or third space to share health information. Ideally, this safe space is outside of the clinic. It's in a dedicated time slot away from daily stressors, so people really have sort of the time to focus on using and sharing health information. But it can also be established by stakeholders themselves if there's a need for it. In the interest of time, I have not focused a lot on the different frameworks that are part of the health information literature. But what I do propose is to have an additional framework for to substitute the ones that are already available, which mostly focus on routine information use within the health system. And you can see that here on the screen. So what I propose is an inclusive health information framework, which does not only focus on the use of routine information for a select group of health workers, but instead recognizes the importance of different types of information, which can also be self-collected, and you can see that in box 1. And this information should also be available to a diverse group of health stakeholders, which is outlined in box 2. And when this group of health stakeholders have access to a diverse set of health information, they also have to get the opportunity to make sense of this data in a dedicated sort of third space or safe space, which is outlined in box 3. And this process can actually only happen successfully when you recognize the larger economic and social context that impacts the health system. So there are several socioeconomic reasons why people might not have as much access to health information, or why health information systems are not working optimally. And you have to be very cognizant of that when thinking about strengthening the access to and use of health information systems. So having said that, and walking you through 3 different case studies, as well as some discussions around my findings, why is the improved access to and use of health information important for the health system going forward? Well, both the health system and disease management in South Africa are becoming increasingly more complex, which requires new ways of thinking about health information systems. For instance, comorbidities and the rise of NCDs requires the health system to provide integrated care. But the health system is also moving from a siloed and curative provision of care to a comprehensive care system, focusing on both prevention and management of long-term conditions. And also the community in health system strengthening, the community is becoming more and more involved as active actors in the health system, which means that they need the right tools to be, to make the impact, to make impact in the health system and to be part of health service delivery. Therefore, as my last sort of statement, there's a need to strengthen the access to and quality of care in South Africa. Health workers and communities require more relevant, context-specific health information to be available to improve decision-making within the health system, as we are, dealing with new health challenges, and our health system will only become more complex from here, not less. So if you want to read more from my thesis, I've written a couple of outputs and attended a couple of conferences. And you can also go to the ILAM website for more resources from the ILAM work specifically. And lastly, I also just want to give a big thank you to my supervisors, Christopher Colvin and Sarah Cooper, who've been really essential in making this writing this thesis. Mandla Majola and Pumzile Niwaji, who have been the ILAM champions on the ground, and without them, this work would not have been possible. As well as the full ILAM team and all the participants and key informants that were willing to chat to me and gave me all the input that I needed to write this work. I think that's it.
Thank you so much, Myrna. That was fantastic. It was really interesting to hear about your work, and we can open the floor to questions. So do people want to pop their hands up. Lucy, do you want to go ahead first?
Thank you. Thanks very much. Thanks, Myrna. It's great to hear it and to see it and to see you. So thank you. In a way, I don't have a question, but I just wanted to comment on the richness of the work and how it has resonance for me given the sort of work that I've been doing as well. And I think I agree entirely with that idea that information is a critical entry point to leverage health system change. But I also really agree and value the way in which you've delineated and spoken about how information we need to expand our understanding of information, and the stats is not the only thing that matters. There's a wider range of information that is important, and that we need to create spaces where different people can come together to engage with data, building relationships at the same time, sharing their knowledge of the situation, and in that way leveraging action that follows. So, I mean, I appreciated all of those points and wanted to, acknowledge that they really have resonance for me in the work that I'm doing, and it's very much, in line with broader health systems work. So, really good to see it, and thank you for it.
Thank you so much for the compliment, Lucy, and I really do appreciate your comments on this work and the impact that it hopefully will have on health systems strengthening. And I remember the last little bit that I wrote of my thesis, sort of like the conclusion about was just after the second research in Daba, where we had more than 500 people coming, community members coming to actually listen to the research that was done by UCT within the community, and seeing like the need to create these open spaces and open dialogue, whether in mass or in smaller groups. And sort of like it's only a combination of both the information provided, the relationships that people have with each other, and sort of an opportunity to actually do that can impact the way that we think about health information, and to broaden the idea of health information, of something not just being a routine exercise that's only been done by health managers who use it mostly to have conversations with their managers about how it's going in the health system, but to actually broaden the impact on what we could do with this information. So thank you so much for acknowledging that. It's really great to hear.
Thanks, Lucy. The next person I have is Pancho Cohort. Sorry, I'm not entirely sure who that is, but you can go ahead and ask your question.
Hello.
Hello.
Yes, I'm from the 2014 cohort of the MPH. That's why I named myself that way. No, my question is, amazing presentation. I loved your ending with your 3 boxes. And it's so important because it's moving towards a participatory understanding of epidemiology, so that we don't just have this information on disease, but we're actually moving to bridge that gap between just describing disease. There's so much COVID, there's so much HIV, to actually acting. And I think my question then comes to, when we talk about an emergency such as COVID, we see now, especially here in Global North, people are rushing to vaccinate, and they've actually fallen in a sense because they've done a lot of reach. But if you look at the UK, for example, a lot of Black people are not really vaccinating in the same numbers, and yet they're very vulnerable. And I guess perhaps they skipped those 3 steps, they just rush ahead. So how can we actually use this approach, which is it's actually what we need to do when we have a health emergency, and then the health information can trickle down, not just trickle down, but people use it and in the 3rd space, and then of course make sure the interventions reach those who need it. That's my question. Yeah, how is that amenable in an emergency when people are rushing to just get things done? I hope it's clear, but amazing.
Yeah.
Thank you.
Thank you so much. That's a really big question to ask, and I don't think I can solve it, especially the whole context of the COVID epidemic. But just just a few like remarks from my side about it, which probably won't answer your question at all, but is to in terms of like the COVID-19 situation. First of all, it's a very new epidemic, and information evolves so rapidly that even as academics, we have to be constantly updated through the various networks, and we are even closest to the source. But I think in terms of providing information and sharing information is to get a diverse group of people together, and not excluding one group or another based on whatever category they are excluded on. Is I think a very good first step, but also to recognize the fact that information might has to be adapted for different groups in different ways, not just in terms of language, but also in terms of specific either religious context or cultural context that might come into play when you're thinking about something like vaccinating, and especially in a health crisis or like an epidemic that we are in now, which is a very new, that it wasn't there when I submitted my thesis, so it's a very like new thing, right? Is that you also really need to work with what you have and try to educate people with what you have. And I was even in like a talk about the clinical trial in South Africa and vaccinating healthcare providers, and even the doctor in charge said, like, go out, if you speak to patients, go out and tell whatever you know to one person and try to convince them to get vaccinated when they can. And I've been recently going out for my own interviews for my postdoc in the community, and that is exactly, if you ask them, do you have questions? They said, when are we getting vaccinated? And should I get a flu vaccine for this year instead? Like, that was a question I got yesterday. So I think we also need to, we are not expert, I'm not a, we're not virologists, and that's okay. But when people ask for it, to be honest about not knowing the whole truth, but being able to share what you do know. I think that's, that's an important part of the conversation. But thank you for that. I hope I answered a little bit.
Thanks, Pancho. And then Eleanor, you've got a question. Do you want to go ahead?
Yeah, thanks. And thanks so much to Myrna for the presentation. It was really interesting. I think my question is around the ideal clinic case that you mentioned, and the need to collect that data really rapidly to be included in the ideal clinic program. And I remember at the time that there was a lot of like nervousness and consternation about just how much data it was that was required. But even then, it seemed sort of that the amount of information required was a bit beyond the sort of scope, or what really should be the scope of the facility manager to collect. I was wondering if what happened after that, like how the data that you submitted, given that it was sort of culled from various sources, and some of it was tacit knowledge and some of it was collected by the facility managers from the community, was that well received? Like, was that what the data that people were looking for?
That's a really good question, and I don't have an answer to that, because unfortunately the clinic that I worked with in Gugulethu closed because it was a satellite facility, and the clinic manager moved over to another facility before she was actually accredited as an ideal, for the ideal clinic policy, which is, was really sad to hear. But I went to Joburg to actually speak to people from the National Department of Health, and I actually asked who were the people who should validate what of the information is correct and if it's enough within the clinic. And the only thing that lady from the National Department of Health said, no, it's and I asked for like an example as well of a perfect one. And she said, like, no, it's just for the clinic themselves to sort of start thinking about the health needs of young people. And then the profile stays in the clinic. It doesn't go out to like any other places. It stays in the clinic, and then it can be used for clinic staff. But she couldn't really answer on like there were eventually, we were able to get hold of a couple of guidelines, sort of like guiding principles that what should be included in the profile, but I've never had answers on like when it was complete enough, or what data was really needed, or should or should not be included in the data. So that all remains, at least from what I knew when I was working on the project, and I hope it has improved since, remained pretty vague, which sort of points to like the lack between a great idea when developing a policy and then the complexities that come around when you're actually implementing it on the ground, without having good sort of guidelines and templates for things that require large amounts of data.
Thank you. So we have a question from Bay in the chat. Bay, are you able to ask the question, or do you want me to go ahead and ask it for you?
Hi, everyone.
Oh, there you go.
Yeah, I can ask the question. It's exactly what's in the chat. I was just wondering from Myrna. Actually, I'm curious about a few things. So I was wondering what you think future health information projects should focus on, specifically in our context. And then the second sort of thing I was thinking about now was what happened to the task team and sort of sustainability aspects related to that after such a long, big project ends?
Thanks.
And great presentation, by the way, very good.
Thank you so much. These are difficult questions. Research gaps and what we should think about in our context in terms of health information going forward. I think that as we move more and more to like an inclusive health system where community members are becoming integral parts and stakeholders within the health system, which has been, and community health workers, which has been tested out in the some sites as well in Cape Town, is that I think there's a big need to include community members and community health workers in information sharing. And there are a couple of examples that have been developed throughout Africa around community-based health information systems, which all gave really great results, but were all pilot projects and never implemented large scale, and were often used to get information from the community to feed back to the health system instead of the other way around. So I think that is like something to really work on, and to also ask the community NGOs and community support groups who are helping the health system and are becoming bigger within the health system to see what their information needs are, because you can develop interventions and tools for even and community-based health systems, information systems, but if you don't focus on what data is actually needed for them to do their work or their community engagement work better, I think that's one big important health information sort of project and gap. The second one, I think, is just opening up databases for the health system beyond only management. Very often frontline workers don't have access to needed health information, or only write the reports and feed it into higher levels of the health system so managers can use it for their reporting. So I think to opening it up to people across the health systems level, including especially healthcare promoters, for instance, and health educators and people who are really like frontline nurses and frontline workers, I think it's really an important part of it. And yeah, so I think those two. And then what's going to happen with iAlarm is not, I think, not 100% clear at the moment. I think the ideas of keeping the iAlarm task team together for as long as possible without necessarily the involvement of the iAlarm project or funding was one of the things we really wanted to do with the iAlarm research team. But then, especially with COVID, that hits that completely sort of disengages. But I hope that there are a couple of funding proposals in the pipeline that is trying to at least have part of the ILM work continued, and I really hope that those will be successful to to at least not let it completely disintegrate. So I really hope that we are able to do that.
Thanks very much, Myrna. That was some of my comments as well, and questions around sustainability. So it's great that we're thinking about it, because I think there's huge value clearly in the results that you've shown on a number of different levels from a number of different perspectives. We have hit 1 o'clock, so I think we will end, and we've lost a few people already. So I think we'll end here. Thank you, everybody, for joining us for this session. And thank you very much again, Myrna, for the presentation. It was really fantastic and lovely to hear more about your work. And I hope everyone goes and takes a look at your publications. They look really fantastic. I got a notification about one this week, which is exciting. So good luck, and good luck with your postdoc. And we hope to hear from you again soon.
All right. Thank you so much.
Thanks, everybody.
For the
Have a lovely
invitation.
afternoon. Thank you.
All right.
Bye.
Thanks.